that first fogging from the ventilating, they're
Well, they're good for
accurate.
they're good for 3 hours, so you can leave them on and use them.
We use them to check to make sure that we're in, and then we remove them.
And then you remove them. But what happens if your tube comes back out?
Then we get a new one to put back in.
But how do you gonna know your tube's out? Unless you leave it on.
Patient's not ventilating, it sats, drop. I mean,
Why not
looks
leave?
bad,
I guess my
looks like
point
it's
is, why
bad.
not leave it on? If it lasts 3 hours, why would you take it off?
Because I've always, I just,
Because they don't
once,
work well after they get wet.
when they get wet, just like you said,
That's the problem.
there you go.
All right, it's all good stuff.
After the first initial 6 bucks, they're no good anymore.
It's sweating now.
Oh, yeah.
You shouldn't drip on them.
Yeah. Well, that guy
Our
has to
patients
go
tend to
somewhere,
throw
you
up
know?
in. Once they've been thrown up in, they're just
Oh.
useless.
Once we get the capnography, it would be
A little bit better, yeah.
Life will be good again.
Soon.
So what's the diameter times 3? What's that all out there?
Oh, that's kind of the old pals thing about how you determine how deep to put your ET tube. I'm still a fan for, you have ET tube markers on the pediatric tubes. Those are called vocal cord markers, and you just use those for the size of your kid. There's really no reason to be using all these other things out there because most people aren't going to be able to do that at 3 in the morning, right? I don't know about you guys, but
So you have a smartphone.
you're kind of befuddled. So
That's right. Hold that breath.
Yeah, let me get that out.
So some of this is not what people are doing anymore here. So, who's currently doing RSI, Hannah? Well, you want to go through what stuff you're using then for your meds?
On kids we use atropine, and then for opioid we have fentanyl or Dilaudid, and then we use Versed along with that as our sedative. If the patient's hypotensive, and as long as it's not cardiac, we use ketamine instead of those. And then we use succinylcholine as long as there's no contraindications for that. If there are, then we have vecuronium. And then to maintain, we use vecuronium instead of succinylcholine for our paralytic.
Do you have paralytics up there and what their half-life is and how soon that they take effect? Do you have anything of that up there? Do you have a slide on that?
When we were going through, we didn't see any slides that had that.
Onset, there we go. So here's fentanyls. These are really important to know for your RSI drugs because it's hurry up and wait when you do an RSI. You have to wait for the medications to take effect before you can actually go ahead and do the intubation. So it's really important that you know these times so that you're not putting your tube in too early and you're going to cause laryngospasm or something. Okay, so there's etomidate. So your onset is 30 to 45 seconds. It lasts about 3 to 5. Are you guys using the 0.3 milligram per kilogram? Is that what you're using for etomidate? That's pretty common.
That's what we used on our stabbing.
About 20 milligrams.
We gave him 30 milligrams.
You gave me 30.
Yeah, he was a bigger boy.
It was really big. So you have your sedation. Do you have your paralytics? Is there one of those in your little?
It says it activates the seizure foci. Does that mean that if you give etomidate and they're a seizure patient, they're going to have a seizure in it?
It's one of the possibilities. There's some drugs in the RSI thing that they'll list it in the protocol. Like, don't use this med on, like, say, burns is one. So you guys are using Versed, did I hear?
Yes.
Okay. All right, you want to flip up another drug up there? Proferol. Matt, you want to talk about that? That's one of your favorite drugs.
What's that?
You want to talk about Proferol? Go ahead.
Michael Jackson. I'm not a propofol expert.
Not either. We won't use it.
Oh, you're not going to use it?
Nope.
That has to be refrigerated, doesn't
It has to be refrigerated, but people doing transfers really like this drug because it, you can see that it comes on pretty quick. And if you're doing it as a drip versus a bolus, you can kind of keep that patient sedated during the transport a lot easier than rebolusing a lot. So propofol is kind of one of those drugs that people that do transfers
It's a lipid
usually
base.
gets that, and it is lipid-based, which can be an issue.
But once you start it, you don't, if you're on a long transfer, you better make sure you have enough. You don't wanna run out before you get there.
Right.
You
So
have
what's
to
a
slowly
drip
increase the
usually?
amount of that.
Oh, never mind. It's listed right on there.
I think it's up there for, yep, induction and then sedation infusion dose. There you are. And most of you are probably using pumps, aren't you? Yeah.
This is pretty slick stuff. I mean, they come up the stairs from anesthesia and they put it on a patient. We're gonna do a
Right.
nasty procedure on it. We do the procedure, we shut it off, and they're ready to go home in half an hour. So it's pretty slick stuff.
Conscious sedation.
That's,
This is one of the biggies too for it. You have less trouble with nausea and vomiting. Some of these drugs are really important for when you're doing induction. It's like one of the last things you want them to do is like upchuck on you, yep, while you're trying to get that going. Okay. Another favorite one? Yeah, you think you're in Wonderland, huh, when you're doing ketamine?
PCP.
Where did ketamine come from?
We used it as a anesthetic for veterinary guys.
Yep, the vets were using that for years when they were doing anesthesia. And then,
It actually started in the military a long time ago.
well, I'm sure the
before they were using
I'm sure the
as a
military's
veterinarian.
done every drug before us, no doubt, and probably has done other things with it too.